pleasant evening, everyone, and welcome once again to the webinar series by the Caribbean Regional Midwives Association. This evening's webinar focuses on long-acting reversible contraceptives, strategies to understand and improve the uptake. At this point in time, I will now hand over to Dr. Curtis to bring us our welcome remarks.
Good evening, everyone. It is nice to see all 140 of you on the chat on time. I know that there are more to come, but welcome to those persons who are here and prompt. Tonight, we are in for another exciting webinar on family planning methods. Today, as Kathy Ann said, we will be talking about long-acting reversible contraceptives. Now, we are aware that as midwives, our skill sets and differ from region to region, but what we want to ensure is that our knowledge base are on par. We would hope that as we move forward and in the future, and as the skills of the midwife is acknowledged across the Caribbean, that we will all be on the same page as it relates to our practice. Right now, we know that in most of our regions, the doctors are doing a lot of the long-acting methods, but in some of our regions, some of our midwives do have the privilege of practicing at their prescribed level. And we are excited about that, but we hope that we would move, the rest of us would move forward and catch up. And so that we will actually be practicing at the level that our certifications prescribe. But until then, we will keep our knowledge base rolling. And we hope that this information tonight will help to prompt you to advocate for the practice of actually inserting on participating, not just in the education, but in the actual performing of these methodologies, which are really less complicated than delivering a baby in a breech position. Okay, but we thank you all for being here. We hope that you enjoy the webinar. Let me say from now that there's no need to put your information in the chat for your certificate, because the certificates will be administered based on your answering of the final questions at the end of the webinar. So there will be a Google form address. You have to click on that, fill out that information, answer those questions, and your certificates will be emailed to you. Okay, but thanks for coming. Remember, everyone, keep your mics muted for us, please. We are recording and we don't want to be disruptive to the presenters. We are more than happy to have our colleagues from Momentum Global Country Leadership back with us again tonight. And Kathy Ann will be doing the introduction, but they have been so good that we keep coming back for more. So I just want to say thank you to Ann Pfizer and Mark Hathaway for continually being of support to CRMA in the family planning and reproductive health area. With that, I will turn it back over to Kathy Ann, and welcome.
So, as mentioned by Dr. Curtis, we have two renowned presenters here with us this afternoon. And we start with Annie Pfizer, who holds the Master in Health Sciences, is a recognized public health leader whose family planning and reproductive health program and implementation research experience span 25 years across 19 African and Asian countries, including long-term assignments in Indonesia, Ethiopia, and Kenya. With a combination of technical expertise, strategic thinking, operational and managerial skills, she directs the family planning and reproductive health work on the USAID Momentum Country Global Leadership Project. Among her repertoire, she served as an author and technical expert for several of USAID high-impact practice briefs for family planning. Earlier in her career as Ethiopia's country director, where she directed USAID and CDC awards and expanded programs from training to a range of qualitative research, service, quality, and human resources for health. We then have Mark J. Hathaway, medical doctor who holds a master's in public health, is a board certified OBGYN who was on Washington Hospital's OBGYN faculty from 1997 to 2013. There he developed and led the section of community outreach, the family planning section, the Ryan Residency Program, and the Family Planning Fellowship. He currently serves as a senior technical advisor for JPIGO, an international NGO affiliated with Johns Hopkins, and as the medical director for CARAFEM, a US-based nonprofit abortion and family planning entity. Dr. Hathaway holds appointments at Johns Hopkins Department of OBGYN and at George Washington University as Associate Clinical Professor of Healthcare Sciences. He also serves on the Board of Directors of Population Connection. Dr. Hathaway teaches, lectures, and advocates for family planning and maternal and child health care access issues nationally and internationally on a frequent basis. At this point, Dr. Hathaway and Dr. Pfizer will do a refresher before going into their presentation.
Thank you so much for a wonderful introduction, and good night and good evening to all of our colleagues in the Caribbean. It is so much fun to watch the names of people and the countries that come in. It's especially for those of us who have been in some cold weather in the last month or so. So it's really, really nice to see everybody. I'm going to see if I can get this to fill the full screen here. Let's see.
Slideshow.
Yeah, go to the bottom where you see the little icon in the bottom strip of postpartum of the PowerPoint. Yeah.
Thank you.
No, not that one.
Oh.
The one right next to the minus sign. That one.
Beautiful. Thank you. It's covered up by my toolbar. Now. now.
You want to go back to the first slide.
Right. Okay, here we are. Thank you. And maybe what I'll do is close out my video. So tonight we've embedded some questions into some polling questions into some refreshers. And those of you who have been with us before may recognize some of the questions. And we thought it would be a great opportunity to hit on some of the main topics as we go through and talk about long-acting reversible contraceptives. And I'm not going to dwell on a lot of these topics because, as I said, we've mentioned them before in previous webinars. And if you weren't on those previous webinars, you do not need to worry. You will have adequate time to catch up and catch the main points. And I want to reiterate a bit of what Dr. Curtis mentioned, that you all as midwives do many, many, many more things that are much more complicated than placing an IUD or an implant. And breech delivery, I would say, is even a normal, regular vaginal delivery is a touch more complicated because lots of things can go wrong pretty quickly, like a shoulder dystocia or a hemorrhage. And so I mention that because I think putting in an implant or an IUD is pretty darn simple compared to lots of other things that you all do on a regular basis. Yet at the same time, I know there's a cultural shift that may need to happen, and we want to empower you, and so you learn about long-acting reversible contraceptives. They're such a fantastic way to help a woman or couple avoid an unplanned, unintended pregnancy. So empowering you with the knowledge, you can serve as advocates. You can serve as advocates for your clients and for your colleagues as well, and encourage them so they know the information. So this is the points that we're going to cover tonight. We're going to define long-acting reversible contraceptives. We will go through a bit of the mechanisms of action of each of these methods and compare how their effectiveness is with other contraceptive methods. I'll touch on some counseling strategies and clinical tools that can help you discuss and explain long-acting reversible contraceptives and some basic concepts regarding contraceptives, and then explain postpartum and post-abortion. And that topic, the latter topic, we'll touch on more than me. Okay. Sounds like we have somebody that we need to maybe mute.
Can you mute your mic, please?
Thank you. So what are LARCs? LARCs are an ideal way to help pregnancy prevention, including young women, including adolescents. And they're basically incredibly safe, incredibly effective, and incredibly simple. And that's kind of the way when I talk about them, I mentioned they're incredibly safe, incredibly simple, incredibly effective. They're also inexpensive in the long run, the long term, and they're reversible. So they're a fantastic method. They require little to no maintenance, and they have much better continuation rates than lots of other methods, including the pill or the Depo-Provera injectable. And they're, as I say, the continuation rates are much higher as many folks wouldn't typically expect. So the first one we'll talk about is the non-hormonal IUDs, the copper IUD. And it works by preventing fertilization. It stops this viability of the sperm or the motility of the sperm. So it's the sperm cannot swim and never meets the egg. So it prevents fertilization, as opposed to other methods that might prevent fertilization in other ways. But the copper ions that are released from the copper IUD release small bits of ions or small material that affects the viability of the sperm, so that no longer or cannot get to the egg. It's also immediately effective. So once placed into the uterus, it's immediately effective and can be used for emergency contraception, which is a bit tricky in some settings. But if a woman were to come in and explain that she had unintended, unprotected intercourse 2 or 3 nights ago, you could place a copper IUD and it would help prevent an unintended pregnancy for her. The trade name that's used in a lot of countries, it's also known as a copper T. It's Paragard. That's one of the trade names. It's approved for up to, and I use the phrase up to 10 years. It's actually effective for up to 12 years, but it's a long time, in other words. But up to is important so that women and clients understand that you don't need to keep it in for that long. If a woman says, well, I don't want something that long, I just like something for 2 years, it still will work for 2 years. So it's important to emphasize up to 10 years or up to 12 years. It's the most effective method of emergency contraceptive, more effective than some of the pill tablets that are available. And its mechanism of action, as we mentioned, is the copper ions decrease the sperm motility. One of the major changes are bleeding issues. And so some women tend to have slightly more cramping and slightly more bleeding after the first several periods after insertion. Some of us refer to that as kind of an adjustment period. Most women after that time frame do not notice a change in their periods, but women will have a period monthly using a copper IUD. Now we're going to move on to the second long-acting reversible contraceptive method, the hormonal IUDs. And I know that in lots of countries, the terms or phrases used are IUCD, intrauterine contraceptive device, or intrauterine system. But the WHO is encouraging us to stick with something a little more standard and call these methods hormonal IUDs. The mechanism of action is slightly different, or actually quite a bit different than the copper IUDs. It works mainly by thickening the cervical mucus along the cervix. So I've shown my arrow down here, and that then also it also acts by inhibiting sperm movement and a bit of an impact on the ovaries themselves. But the main mechanism of action is a small amount or a systemic amount of a hormone that acts principally on the uterus itself and at the cervix. So again, the sperm never meet the egg, prevents fertilization by blocking that sperm from getting into the egg. There's 2 products, I believe, and I want to mention, and now that I'm remembering this, we had a brief conversation with several of your colleagues, Diana Henry from St. Lucia, Chanel and Norma from Trinidad and Tobago, and Dr. Curtis from the Bahamas. And we talked about the various methods that are available in different countries. And these are the 2 that are available, the hormonal IUDs that are available in the Caribbean. The Mirena is a Bayer product, and Elora is a product by DKT, or oh boy, that's not correct. I forget the manufacturer for Elora, but they're basically the exact same thing, the exact same size. The inserters are slightly different, but they're the same product or the same IUD. They work the same. And this is a bit of a blown up picture of it. Sometimes when I'm talking, maybe I'll show a little later, when I'm talking with patients, I have a placebo in my hand so I can show them what it feels like, what it looks like. Very, very small, it's flexible, pliable. And the hormone that's released from these two, the hormone is a levonorgestrel, that's the LNG, which that's what that stands for, LNG, levonorgestrel, and is a 52 milligram release milligram amount, but it releases 20 micrograms per day, which doesn't really matter that much, but it's a smaller, much smaller amount of a hormone that's released daily by this reservoir that's on the vertical bar, that part that's a little bit thicker that you can see. It's approved for, or better said, it's effective for up to 7 years. Both of them are the same. In some countries, the approval may be for less amount of years, but we know from many, many different studies that these methods are effective for up to 7 years. But again, if a woman says she would like to use something for 2 years, 3 years, and not that long, this is a fantastic choice for her. She doesn't need to keep it in for that long a period of time. And they come out very simply. This next slide, I'm going to talk a little bit about, and I'm going to focus first on the slide, I think, depends on how these pop up, but I'm going to try to focus more on the IUD truths, because those are the ones, actually, sorry, we'll focus on we'll go through some abortifacient or some myths on the left side, sorry. So some of the myths are that IUDs cause abortions. They do not. Another myth is that they are large in size. They're not, they're very small. They're very pliable and very small. There's another myth that they cause ectopic pregnancies. That also is a myth. These do not cause ectopic pregnancies. In fact, they are one of the best and most effective methods of reducing the risks of an ectopic pregnancy, because the chance of a woman getting pregnant at all is almost zero. They do not cause pelvic infections. That's also a myth that's been thrown out for many years. They decrease the likelihood, the likelihood of future pregnancy. They do not do that. A woman that's a nulliparous woman or an adolescent can safely use an IUD. It will not decrease her ability to get pregnant again in the future. They do not necessarily need to be removed for pelvic inflammatory disease. So if a woman has a pelvic inflammatory disease and she has an IUD in place, you can treat the infection and leave the IUD. If she doesn't get better, you need to take it out, but you can leave it in safely and treat her without taking out the IUD. There is no need to remove an IUD for a pap smear, for example, or if there's inflammatory changes on the cervix and a woman needs a pap smear, you do not need to remove the IUD before, or if she has that on her cervix. And there's another myth that often comes up that, you know, an IUD will cause a problem if I do become pregnant, and that is incorrect. The IUD doesn't get into the amniotic sac. It doesn't get into, if a woman, rarely, incredibly rare chance of her getting pregnant with an IUD in place, will have no impact on the fetus growth or development. So these are all myths and these are all not true things, but the more important, focus on the truths. So they can be used by women who have had an ectopic pregnancy. They can be inserted on the same day whenever a woman is with you. They can be started immediately postpartum and post-abortion. Now we'll talk a little bit more about that. They can be used for nulliparous women. They can be used for adolescents. And they have pretty darn high continuation rates, much higher than other methods. So this is a slight range, but the rough range for continuation rates at 1 year is about 80%. The next method, or the third of the 3 LARC methods, are implants. And there's a couple that are available in your countries, 3 actually. And the implant works in 2 different ways. It works by having an impact on the an inhibiting ovulation, slightly inhibits ovulation, and it also thickens the cervical mucus because it's a progesterone, it's a progestin. So it suppresses the hormones for ovulation, and it also thickens the cervical mucus to block the sperm. And these methods are also immediately effective if inserted during the first 5 days. We typically tell women if they're using any method other than a copper IUD, the rough rule of thumb is they are effective within 7 days, they are effective at around 7 days or more. So we usually tell women if they're starting a birth control pill, for example, or if they're starting a Depo-Provera or a patch, you can let women know that they're effective pretty darn quickly, but they should use a method, a backup method for those first 7 days or so. That's a rough rule of thumb for all contraceptive methods except copper IUD, which is immediately effective. These are the methods that are available globally as well as in the Caribbean. The one on the left, the Levoplant, that's a 2-rod system. The one on the bottom is another 2-rod system called Jadel. And then the one on the top right in this picture is called Implanon NXT. And there's a pretty handy device used to insert Implanon NXT, and that's a 1-rod system. I've shown this little picture in the middle here that has the insertion that with a 2-rod system goes in the upper arm. The 2 rods go off at a slight angle with a little bit of a trocar that's used to place them. This is showing a removal step, but there's a very simple little trocar. You can see it kind of down in the picture on the bottom. For the Jadel method, there's 2 rods. They're about the size of a matchstick. Again, very small, very pliable. And then there's a sterile trocar or an insertion tool that comes with the package, and that's used to insert them sterilely through one small little incision. Very, very simple technique. I've highlighted this one just a little bit because it explains a bit about the hormone. In the Implanon NXT, it's a 68 milligrams of etanogestrel. The other 2 methods, the Jadel and Levoplant, are actually levonorgestrel. All of them are progestins, which make them incredibly safe, very, very safe for just about any woman or any woman that would come to you. They're incredibly safe because they do not contain estrogen. None of the methods that we're talking about today contain estrogen. We'll touch on that a little bit later, but because they're progestin only, they're very, very safe. And even though it contains 68 milligrams, it releases a 30 to 40 gram microgram per day, which is enough to slightly inhibit ovulation and slightly or prevent thicken the cervical mucus so that the egg and the sperm never get together. It's placed in the upper arm, as I mentioned, and it's approved. All these are approved, or better said, they're effective for up to 5 years. So they're effective up to 5 years, and so it may vary what the approval is in your particular country about the duration of use or the approval, but they're we know that these methods can safely be used and prevent pregnancy for up to 5 years of use. So if one were to ask a question about the progression of effectiveness, where would you place LARCs in this grand scheme? I have another diagram I'll show you in a little bit, but we're not going to be able to ask or have people answer this question yet, but I'll point. So LARC methods, IUDs, the copper IUD, the levonorgestrel, hormonal IUDs, and the implants are all as effective as vasectomies or male sterilization and female sterilization. They're as effective as permanent methods. They're incredibly effective. And they're more effective than progestin-only injectables, like the one that's available in just about every country is Depo-Provera. They're more effective than combined oral contraceptives, condoms, standard days of fertility awareness methods. So they're incredibly effective, and yet they're reversible. this is another way of looking at kind of the same thing. So the top methods, male sterilization, female sterilization, implanon, there are Nexplanon, and I'm sorry, the hormonal rods or implants, the intrauterine contraceptives or the intrauterine hormonal IUDs, the copper IUD, all of these are incredibly effective and as effective as sterilization methods. The injectables are pretty close, but they drop down. And this is 1 year of typical use, which is how we measure contraceptive effectiveness methods, or how we measure the effectiveness of contraceptive methods. I mentioned a bit earlier about continuation rates, and I love this chart because it shows how continuations rates compare with some of the other methods. So you'll see the hormonal IUDs at the top. The next one down is the copper IUD. The next one down is the implants. And then the third category is non-LARC. So that includes pills, patch, rings. And you'll see in the top bar is 1 year continuation rates. So roughly 80% or a little bit more. And then at 3 years is the reddish bar, and the IUDs are about 70% continuations, and the implants are 56%. So these are some of the most, the methods that have really, really high continuation rates. And one can argue, well, that's not such a fair way to compare things, because if you want to discontinue your IUD or you want to discontinue your implant, you have to go somewhere and have it removed. And that is a problem in some places where folks, clinicians, providers may not be trained on removals. However, we know from this same study that was done in a large US study, women were asked the question if they, when they continued these methods, would they recommend them to their friends? And it was almost exactly the same. They said, yes, we like these methods, we continue them, and we would recommend them. So they not only showed that high continuation rates, but high satisfaction rates. It was one of the largest studies done on contraceptive methods anywhere in the world. This is kind of the same thing, again, just a little different way of showing it, but 70% of, this is at 3 years, copper IUDs, women tend to use them for 3 years or more. 70% of hormonal IUDs, continuations, and implants slightly less, around 56%. That's compared to 30% of pill, patch, ring users. Those methods tend to fall off pretty quickly. Women discontinue them for a variety of different reasons. And here are some of those reasons why women discontinue. And this is a bit complex chart, but you can look and see the top reasons why women discontinue have to do with bleeding changes. And sometimes there's good ways to help women get through those bleeding changes. Other times women are just kind of tired with the bothersome nuisance bleeding. They want the implant or the method removed, the IUD or the implants removed. The next one has to do with pain, and then side effects. That includes those items above. And then the numbers start dropping down. There's very few expulsions. So this notes 12 and 14% of IUDs, which is quite a bit higher than normal, or than most studies. And then there's some women want them. Some women want the methods removed because they want to become pregnant. And method failures at the bottom part of this chart are very, very low, 1% or less. All right, here's where Shirley gets to do her stuff. So we're going to bring up I think, Shirley, if you bring up one question at a time, and we'll go through one question, we'll give everybody about maybe 5 or 6 seconds to answer. And then we'll cover several topics. Many of them will be reviewed from what we just did.
Yeah. Okay, is Everybody is seeing the poll?
Yes.
Awesome. Okay, we have 309 persons in the, so we would like for everybody to participate, please.
Yes. I think today send me a certificate, right? My thing open.
Nope, just answer the questions. The one for the certificate will be at the end. Mark, are you seeing,
So
We could-
Alden has a hand up.
sorry?
Someone has a
Yes, they
hand
have
up
hand up.
raised.
Alden Robbins.
Hi, good night. I'm not seeing the questions.
Okay, so it must be that you have an older version of
Vision
Zoom.
Yeah.
Basically, the question is saying LARCs include IUCDs, hormonal and copper, and implants, and your options are true or false. So you can probably just put it in the chat.
Okay, thank you.
You're welcome. Okay, so I think we have 96% of persons saying true, 4% of persons saying false.
Great, great. The answer is true. So LARCs, long-acting reversible contraceptives, include the hormonal IUDs, the copper IUD, and implants. Great.
Okay, so I'll stop sharing that one. So you want the second question now?
Please.
Okay. Uh-huh. Um, all right, now I'm not seeing my second question. Okay, here we go. Is it visible?
Yes.
Good.
So the question reads, the continuation rates for LARCs at 1 year are approximately, and there's several different answers, percentages.
Yeah, 50, 80, 95, or 30. Okay, a couple more seconds. We have .200 persons participating. Come on, we have 312 persons on the line.
Madam President, someone has a hand up.
Yes.
Go ahead, Jacqueline.
Okay. Okay, we'll end this poll. And
The
we'll share
correct-
the results.
The correct answer is 80%. Many of you got
Yes.
that correct. The
Yes,
correct
so
answer,
57% of them got that correct.
great.
All right, so stop sharing that one.
So
There's a-
high
Shirley, there's
continuation rates.
Someone with a hand up.
Oh, I can't see because I'm doing
All
the
right,
poll,
Jacqueline.
so you can go ahead.
Jacqueline. Jacqueline
Oh,
Farmer.
sorry.
Your hand is up still. All right, go ahead, Shirley.
Great. Shirley, if you want to bring
Okay.
up the next question.
Yes. Oh, I think that's the wrong one. But I'll launch it anyway.
Great. So this is the main reason that women dislike LARCs or want them perhaps removed.
So the reasons for those who are not seeing the questions are bleeding changes, weight gain, depression, or unsure. Reasons why women dislike LARCs or may want them removed. Bleeding, weight gain, depression, or if you're not sure, that's D.
People jump fast on that one.
Yes, so
That's
you
great.
can end
That's
that
the correct-
poll,
Yep,
bleeding changes, and most persons, 92% person said that, correct.
that is the correct answer. Bleeding changes. I'm guessing you've plenty of clinicians, midwives have seen those patients come in and bothered by the
Right.
bleeding. Yep. Okay, next one.
I think I missed 3. Let me go there.
So
Okay,
the
for
question-
persons. Okay, go ahead, Mark.
The question reads, LARCs are some of the safest contraceptive methods because A, they last a long time, B, they contain progestins or no hormones at all, C, they contain estrogen, D, they are inserted subdermally, and E, unsure.
All right, we have 106, 170 persons, 180. $200. Okay, I will. Still moving. All right.
Great. So the correct answer is B. These are incredibly safe because they contain progestins or no hormones. All of the LARC methods, implants as well as the hormonal IUDs, are progestin based, which makes them incredibly safe. The estrogen is what makes methods slightly unsafe or tricky for some women because it causes an increased risk of clotting.
Mhm.
So the answer is B.
That was
Great.
close.
Right.
Right.
That was very close.
Yes. 46 and 45%.
And it is true, they do last
They
a
do
long
last a
time,
long time, yes.
but that's not why they're safe. That's
Right.
great.
All right.
right.
So let's, you want another one?
Yes, please.
I think we're on 5 now. Okay, this question reads, the hormonal implants and IUDs are approximately blank percent effective. 80, 85, 99, unsure. So how effective are the hormonal implants and IUDs? 80%, 85%, 99%, or unsure? Okay, we have 200 persons answering. Let's see if we could get up to that 300. All right, so well, let's
So the correct answer is 99% effective. These methods are the most effective methods out there. They are, in some cases, actually more effective than a tubal ligation or a vasectomy, if you can believe that. So you can
Right.
think of them as effective as permanent methods. They're incredibly effective, 99 or more % effective.
yes.
Thanks.
All right. So next one.
Yes, please. We'll
Okay.
do, I think, 3 more, maybe 4.
Okay.
How long do implants last? How long are they effective for? The answers are 5 years, 3 years, 4 years, or 12 years. So these are implants we're referring to.
So your choices are 5, 3, 4, or 12 for the implants. How long do they last? All right, we have 227, 28, 30 persons answered. So
So the
we'll
correct
end the
answer
poll.
is 5 years. So again, I mentioned this earlier that some countries may have different approvals for the method, but we know that all of the implants last and are effective for up to 5 years.
Right.
The answer was A, 5 years. Great.
Mhm.
So the question is, what would be the downside of providing a woman a method of contraception if she is possibly pregnant? What would be the downside? So if a woman is possibly pregnant and you didn't know it and you put in an implant or you started her on birth control pills, what might the impact be on that fetus or the mother? We could ask either one, but
160.
little tougher question. We hadn't,
Mhm.
we didn't cover this one tonight, but I covered it in a previous webinar, but
Okay, we just have just over 200 persons answering. 2 more seconds. All right.
so the correct answer is B. There would be no impact of the pregnancy. I didn't mention this, but it's pretty important to, if you're reasonably certain a woman isn't pregnant, you should go ahead and give her a contraceptive method or provide her a method when she's with you. So the idea is to help her get a method when she's there with you, and you don't have to make her go through extra hoops. So there's, yeah. We'll go on to the next one. An implant can be inserted after the first 7 days of menses, provided you are reasonably sure or reasonably certain that the client is not pregnant. But there should be a backup method for how many days? 5 days, 7 days, 24 hours, 48 hours? Those are the possibilities.
Okay, we're gonna end in 2 seconds. We have 225 persons answering so far. 68%.
Great. So the correct answer is 7 days. 7 days. And that's a rough rule of thumb for any contraceptive method.
Mhm.
A backup method is a good idea to use for 7 days or so. That's great. Thanks. So we'll do one more and then we'll cover a few more topics.
Okay.
On what day of a woman's menstrual cycle can a woman receive an IUD or get an IUD? And the answers are when she's on her period, days 1 to 5 of her period. I probably better read 1 to 5 after her period. Anytime, or D, unsure.
Just over 200. Let's see if we could get 70%. Okay,
Great. So the answer, this
69%. Mhm.
this I haven't really covered yet, but we will in a few seconds. The answer is anytime. So you do not need to have her come in when she's on a period. You do not need to wait or have her, or you could put it in, you know, a lot of people say, well, do it when she's on a period. It's easier to put in, or days 1 to 5 because you know she's not pregnant. Those are okay times, but if a woman comes into you in the middle of her period, for example, and she says she's been using another method and you know she's not pregnant, you can be reasonably certain she's not pregnant. That's a perfectly fine and a great time to put an IUD in if that's what she wants. So in other words, help her get a method when she's with you. Those other choices are okay, but again, help a woman when she's there. You don't need to have her come back or have her come in or schedule because, you know, schedule her when she's on her period or right after her period. That's just making it trickier and harder for her as well as a clinic system. So she could get an IUD anytime as long as you're reasonably certain she's not pregnant. All right, Shirley, if we can take the polls down. And I'll see if I can find my cursor. Is that, I think you need to take the poll down. At least I'm still seeing it.
Can you close it,
Still
Mark?
seeing the poll?
I don't think
It's
I
closed
can.
on my end. Let me try again.
I'm not seeing it either.
Oh boy. Now I don't know what to do here. I can't even find my cursor.
Just click anywhere on the screen. Yeah.
I'm trying. Good golly. Let me try.
Unfold it so the
Oh man. You may have to pull up your screen. I can't get my screen to do anything.
Okay, hang on.
Sorry.
I need to make
You
you
have to stop
co-host then,
share.
huh?
Yeah, I can't share unless you make me
You have to
co-host.
stop.
Okay.
yeah.
Okay, so Mark, you need to stop share then, if you can.
Here we go. Maybe I've got it again.
Yep, you good?
No.
You need to stop share.
No, he said he thought he got it to move, so I was reading. Let me see if I can do it from my end.
I'm so sorry.
Can you,
I'll do
Um,
multiple participants and let me
And make-
see. Try
Make
it on.
yeah, I can do it.
Okay.
So are you seeing the screen now? Here, let me advance.
No,
no, because his screen is still up.
his
It's
screen is
just
still up.
His screen.
All right.
So we supposed to be able to, you could stop his sharing.
Unless,
Right.
okay.
And
There
stop
we
his
go.
sharing.
All right, Mark, yours is moving now. That's fine.
Are you seeing,
Is
Whose
that
screen
yours
is
or
it?
Anne's?
It's Anne's screen.
That's
up.
it
I'm
says
just-
that I'm screen sharing, so just,
Okay, go ahead.
Right,
Um,
good.
Beautiful. That's where I wanted to be. I'm so sorry, everybody. Thanks. So
No?
this is
You're
a
good.
this is a slide that basically we showed one time before. It basically shows different methods and how they work. We'll share this with all the slides with you later. Next slide. So there's many different ways that you can talk to women about different methods. Mute. So there's lots of different ways you could talk to women about different contraceptive methods. And this is a nice thing to think about when you're talking to women and having a shorter conversation. So what are you interested in a method? Are you interested in how effective it is? Are you wanting a method that you can stop as soon as you want? Do you want something that you don't have to think about once it's in place? You don't have to remember to take a pill every day, for example. Do you want to have discretion? So these are all ways that you can talk to women and ask her open-ended questions. What do you want from your contraceptive method? Next. And this is kind of the same thing, though these are just some considerations that may have impact on what a woman chooses. Just ways to think about what might be going through her head or a couple's minds when they're with you and you're thinking about contraceptive methods. So open-ended questions, develop a quick rapport with women or your client when she's with you, and then talk to her about, what is she interested in? Next. There's a something called a tier-based effectiveness, and these are the top tiers. We mentioned them a few minutes ago, that the top tier is a sterilization and LARCs, implants and IUDs, and then the middle tier includes injectables, lactation amenorrhea methods, pills, patch, rings. And then the third tier, the lesser effective methods, are those male condoms, diaphragm, fertility awareness, withdrawal. Those methods work okay, but they don't work as well as tier 2 and they don't work as well as tier 1. That's a nice chart that the USAID and the World Health Organization has put together. Next. There's another chart that I kind of like a little bit better just because it's more colorful, but it's the same thing. It's a nice way you can talk about different methods, show them where they fit. But again, effectiveness isn't the only thing that women are seeking. And so you want to make sure that, what it is they want from a contraceptive method. Next. One question that that's used in a couple of settings in the United States is what's called a one key question. So you can ask a woman, so what would you like to become pregnant in the next year? And she basically has 3 answers. One is, yes, I'd like to become pregnant. 2, some women would say, no way, are you kidding? I don't want to be pregnant next year. And then
Very good. But when you're doing multiple choice, you want to eliminate those
the
that
third
are
answer would be, she's not sure.
and so we don't want to bring extra linen into the room.
So
Right? That's a no-no. Because what you'll be doing is what? Remember I said it
Ms.
before.
McIntosh, would
Remember,
you
don't
mind
use those-
muting, please?
Thank you. So this is just another way that you could ask a question, that and try to get at it, what she's looking for. Next. So these are all kind of some counseling tools that can help. There's something called a teach back, method. So once a woman has chosen, or your client has chosen a method, you can go over it again with her, make sure that you have her reiterate some of the benefits, some of the side effects, follow-up steps. This is a nice thing to use for women to help, or any client, to help them, make sure that you've explained things in their words they can repeat back to you. Next. Anna is going to touch on this in a little bit again. So this is when you can insert a postpartum IUD. These are the time frames. But I mentioned this a few minutes ago. The best time to insert an IUD is almost any time. It's okay to insert an IUD when you can be reasonably certain a woman is not pregnant. That's the direct line from the WHO's selected practice recommendations. Next. And the thing that a lot of people get worried about or nervous about when putting an IUD in is really the only thing you need to do, mandatory thing, is to make sure by looking at the cervix, and if you can look and say, that looks like a healthy cervix, there's no signs of infection or no signs of undiagnosed vaginal bleeding, you can put an IUD in. So mandatory step is to look at the cervix. If it looks healthy, go ahead and put an IUD in. If it looks like there's a purulent discharge, that is a time you would not want to put an IUD in. But the basic rule is mandatory test is and you don't even need to do a test, but you just make sure that the cervix looks healthy. That's really the only thing you need to do. Next. So there's some key points. We've touched on all of these. It's a small plastic device. It's effective for 12 years. Can be inserted any day of the menstrual cycle. Can be inserted immediately postpartum. It requires a trained provider. However, that's the downside. But it also, there's no user action. The woman doesn't have to remember anything once it's placed. And then the spotting irregular bleeding, typically within the first 3 months or so, is basically predictive of what a woman will experience after. Okay, and then there's a couple key points for hormonal IUDs. We've touched on these. Up to 7 years, it's effective. These are placed in the uterus. They're hormones that are systemic, but mainly at the uterus, at the cervix. They can be placed anytime, can be placed immediately postpartum. You need to have a trained provider. There's no action needed. Change in menstrual cycles. A lot of women with hormonal IUDs tend to have very light periods and sometimes no periods at all, which is a big plus for lots of women. Roughly 30% will become amenorrheic. And then implants, they're small tubes, 1 or 2, placed in the upper arm, effective for up to 5 years. They can be inserted any day of the menstrual cycle, provided you're reasonably certain. Immediately postpartum, then you need to be trained. A provider has to be trained to insert and remove, and there's nothing to do afterwards. Monthly irregular spotting and bleeding is common with implants. This, I'm thinking we should move on and let Ann jump to her topic. We're going to touch on the WHO medical eligibility criteria, maybe at the end with a question or two, but it's basically a tool to use we talked about it in a previous webinar. I'm hoping that most of you have downloaded that app, but it really helps you don't have to rely on your memory. You can use the app to determine which methods are safe and at what time frame. And you can include other contraindication or indications that might give you some idea whether or not you could use a method. So the idea is these are the 4 categories. Thank you, Ann. Number 1 and 2, you can use them in any circumstance. Basically, the advantages outweigh the disadvantages. Category 3 is where you want to be a little bit utilize your clinical judgment. In many cases, they would not be, if a method falls under category 3, it's probably not a good time to use it. And then category 4 is contraindicated. This is a case scenario that we could move through pretty darn quickly. basically points out if a woman comes to your office and she has a history of chlamydia 6 months ago that was treated, and she reports one new partner since then, could you place an IUD today? And based on what we said a few minutes ago, we'll go to the next slide. You'd look in the WHO medical eligibility criteria app, and you would put in if she has a current infection, then you would not want to put an IUD in. If she has a purulent cervicitis, for example, if you look at the cervix and it looks unhealthy, so IUDs, INIT, that means initiating, you would not, that's a contraindication. But if she has cervicitis and she's now come to you and she's got an IUD in place, you can leave it in and treat it. There's also no harm in placing an implant in that particular case. A history of an STI is not a contraindication. If she has a current infection, that's a different story. But a history of an STD or an STI is not a contraindication. In fact, you can test at the same time you place an IUD and then follow up with results. Next. So the answer is down at the bottom there. So long as she does not have purulent cervicitis or other contraindications, you can screen at the same time, place the IUD, and then treat her if she needs treatment for an infection that she might detect at that time. Great, thanks. So LARCs are long-acting, incredibly effective, but also easily reversible, needing a provider to take them out in many cases, in all cases, I guess. They will not prevent against STIs or HIV. And you can use a backup method or a bridge method if you're waiting, if a woman's waiting for an appointment. Condoms are important for protecting from STIs, and you should
guess what?
One
I just come tamper with the
one should remove an
document.
IUD or an implant anytime a woman wants it out. There's no sense in trying to encourage her to keep it in if she doesn't like it. And then if it's end of its duration period, you can replace it with another one. 99% effective. So all of the LARCs, incredibly effective, incredibly safe, and incredibly simple to use. All right, I wonder if we should maybe jump on and leave some of the polling questions till the end if we have some time. Maybe Ann, you want to take over? I'm looking at the time. I think I may have pushed.
Okay.
Yep, thanks.
We can come back to these polling questions if people are interested in them. And then
we have time at the end.
okay, great.
Mhm.
So hi, good
Okay.
evening. I'm going to shift and talk a little bit more about the postpartum and post-abortion timing for LARCs. And I saw some comments in the chat about the timing of IUD insertions in particular. So I'm excited that people have questions about this. But before I get into the IUD and the implant specifics of it, I just wanted to cover some generalities about postpartum family planning, and that there's pretty good evidence of that the timing in a woman's life that she has a pregnancy and a baby does matter in terms of her own health outcomes, as well as for the outcomes of her newborn or infant. And these have been summarized as sort of the healthy timing and spacing of pregnancies. And we're focused, when we're talking about postpartum women, we're especially focused on the interpregnancy interval, so the ensuring that pregnancies are spaced at least 24 months, but also to keep in mind that if there are other risks like older age or high parity, these can compound with short intervals to make higher likelihood of negative outcomes for a woman. So it's often difficult to talk about risks with clients, but the idea is to sort of know to focus on talking about postpartum family planning to all women, but in particular to those with multiple risk factors. And so just to define what we mean by postpartum family planning, and this is a World Health Organization definition, it focuses on the prevention of unintended and closely spaced pregnancies throughout the first 12 months following childbirth, but with the hope that women who have adopted postpartum family planning will continue to use contraception for at least the second year after birth to get that 24-month pregnancy interval, and even longer depending on a woman's desire to space and limit future pregnancies. And then in the global FP 2030 partnership, they have been very good at emphasizing postpartum family planning as a strategy and define it as integrating family planning services with the existing care provided by midwives around the world during and before childbirth and up to 12 months after. So with that definition, I wanted to share this graphic, which sort of articulates that postpartum family planning is not a single intervention, that it can happen at multiple times during a woman's life and at multiple visits that you as a clinician are likely to encounter clients. So obviously in the family planning clinic or in pre-pregnancy consultation, it's a time to talk about family planning generally, not necessarily postpartum family planning. But then during pregnancy, it's a great time to make a plan for what will happen after birth in terms of postpartum family planning. And then at the time of birth, it's again a time to talk about integrating both counseling and provision of all methods, including long-acting and reversible contraceptives like IUDs and implants, as well as through all these other visits along the continuum of care. And of course, in pregnancy, if a woman experiences a miscarriage or has sought an abortion, then there's a chance that that pregnancy was not wanted, and integrating family planning discussions in post-abortion care is also critical. And then this diagram also emphasizes the integration with nutrition. And that is because of a method that Mark talked about briefly in terms of the tiers of effectiveness, and that is lactational amenorrhea method. Regardless if a woman is actually practicing LAM or lactational amenorrhea methods, you as clinicians should understand that her breastfeeding practices affect her risk of pregnancy. So if she's exclusively breastfeeding day and night and is able to stay with her infant at all times, then even if she doesn't realize it, she is passively using lactational amenorrhea method and is unlikely to get pregnant. It's 95% effective. However, if there's grandma or relatives who are introducing other foods, or she's gone back to work and she's no longer breastfeeding around the clock, or if she's always been sort of a partial breastfeeder from day of birth, then there's a chance of return to fertility, and she should understand that she's at risk. With no breastfeeding at all, women can begin ovulating after childbirth between 4 to 6 weeks if there's no breastfeeding at all, or if an infant has died. So having that understanding of fertility return and risk of pregnancy is important in the postpartum period. So I also am quickly going to run through a few slides where there are links, and you can refer to them later when the presentation is posted on the CRMA website. But we encourage all the opportunities in that previous graphic at every contact to include a discussion of family planning. And there's good evidence that counseling during antenatal care is very effective in helping women adopt postpartum family planning, as long as it's followed up with integrated services later in the continuum of care. And or if it's sort of multiple sessions to really go into the counseling. If it's a one-off conversation once during one ANC visit, then the evidence shows that it has no effect on later use of postpartum family planning. Similarly, there's pretty good evidence in this high impact practice, and thank you to Kathy Ann for mentioning my role in writing this high impact practice, which is a series of reviews of the evidence that USAID, WHO, and UNFPA have compiled. And in this next slide, you see that where there's been effort at integrating comprehensive counseling and proactively offering contraceptive services at the time of childbirth, between 20 and 50% of women will opt for a method before they even leave that childbirth facility. So it's a highly effective intervention and is further augmented by antenatal counseling beforehand so that people can make up their mind without pressure. There's also good evidence on integrating family planning or postpartum family planning with immunization services. And as you see this is a typical schedule of visits. Again, with the different vaccines offered, there are many opportunities to integrate postpartum family planning and to sort of ask a mom if she's breastfeeding and if she's worried about a closely spaced pregnancy and if she's adopted contraception. And I also put in red something of a more recent study that we've done where we looked at integrating postpartum family planning at every visit from pregnancy to 12 months postpartum. And we found that when women were offered or when family planning was discussed, every single time they had a visit that included a family planning discussion, it led to a 15% higher chance of using postpartum family planning at 12 months. So basically the point is that it's really important to emphasize counseling, emphasize that women should think about their postpartum family planning needs and choices and preferences, and if possible, make a decision, whether it's in pregnancy, and they can always change their mind and change methods later, and also at any time after birth. Counseling is definitely key, but so is also organizing your clinic services and your records to facilitate that integrated care along the continuum of care. So for example, if you have electronic medical records or women have MCH cards that they take with them, is using those to mark when counseling has been provided, whether a decision has been made, whether that decision has been carried forward to the next visit, etc. And it helps. We've done studies that show that providers actually feel that it saves time because they can see that someone else in the clinic has already had a conversation and they can just follow up and continue the conversation. For the long-acting reversible contraceptive like IUDs and implants, the integration also requires having the instruments, having the commodities in the labor and delivery room, so as to make the integration of services as seamless as possible. And then with later visit in the postnatal or in immunization services, there also needs to be sometimes communication because you may have a cadre that just does vaccination and is just being asked to ask questions of a client like, has she considered going for family planning today? And would she like to, skip the queue to talk to a family planning provider? Those kinds of strategies have been shown to be very effective. So Mark has already talked about the medical eligibility criteria, and in the majority of cases, there's no problems with inserting a postpartum IUD, for example, at any time during childbirth, except for this timing issue under category 3. So there is strong evidence that the timing of an insertion should either be very close to childbirth or during a C-section, And then if it's delayed beyond 48 hours, then it's better to wait until 4 weeks. And that is because of higher risks of perforation and expulsions during that period. This graphic here shows that the ideal time is post-placental, but that's more sort of the fact that right after the delivery of a placenta, the cervix is really wide open. And from the women's perspective, might as well get it over with and place that IUD. But actually the evidence is that whether you do it right then and there in the delivery room, or if you which requires that the counseling has already been done during antenatal care and she's made a decision, she's confirmed that decision at the time of birth, then it's great. But in most cases, if she hasn't had that counseling or hasn't had that time to think about it, then you'd probably want to wait until the next morning, have the counseling again, and confirm that this is still the right choice, and insert it the next day or prior to her leaving the facility. And then there was that question about expulsions. So in the past, there were high expulsion rates with postpartum IUD insertions. But what we've learned and have studied now in dozens of countries is that if you use a good insertion technique, a very careful way to place that IUD past the vaginal uterine angle in a postpartum uterus, if you can place the IUD at the fundus, then the expulsion rates is very low. It's roughly equivalent to an interval IUD insertion. So the way to reduce the expulsion rates is to have a skilled provider who knows how to insert the IUD at the fundus. We have great training materials on how to do this, including a video. Here you can see an image of the screenshot of the video that we recommend using a very long placental forceps to place that IUD and to have a very careful technique for removing the IUD, the Kelly forceps without pulling the IUD out. And there's some other very useful videos from our partners at Global Health Media, and we can go into further detail if there's interest from folks. And then I just wanted to make the other last point about post-abortion care and offering all methods of contraception to women after a miscarriage or an abortion, and that long-acting reversible contraceptions like implants and IUDs are part of the choices that should be offered at the same visit. It does require, again, having the materials in the same room where the abortion is managed. And so it does require being prepared to offer those LARCs and to sort of fully counsel and make sure that you have informed choice for whatever method women desires, including perhaps no method at all. And just to say that the training materials that I showed on a previous slide also includes a module on post-abortion IUD insertion and those techniques. So we could go more into detail, and Mark can answer a lot of questions about technique, but maybe we should get to those polling questions, including the last set on the postpartum and post-abortion family planning. So maybe I'll stop sharing and we can pull up the polling questions, or do we need to keep the slides up?
It shouldn't matter. Let me just go to the polls and see. I think we were on question 10. Yeah.
Correct.
Mm-hmm. Can you see it?
Yes.
Awesome. For those who can't see it, it says which family planning methods cause abortions. And you have birth control pills, hormonal implants, emergency contraceptives, all of the above, none of the above, I'm not sure. Okay. If we can get at least 50%. All right.
Great. So the answer is none of the above.
Awesome. None of the above. So
Great.
there's
Great.
the poll. Okay. All right. The next one.
Question is MEC stands for A, medical eligibility criteria, B, meconium, C, mean equivalence in contraception, D, unsure.
Okay. All right. We're almost at 50. Good. All right. I think most of us got the gist of it.
Good.
Although
Great.
only 50-something% persons answered, the results are here. And A was the
Medical
answer.
eligibility criteria, and it's in the form of an app, easily downloaded, free. So hopefully more and more of you are getting that, putting that into your smartphones. Thanks. Next.
Okay. Contraceptive methods that are appropriate for adolescents include implants, copper IUDs, hormonal IUDs, birth control pills, condoms, all of the above. Contraceptive methods that are appropriate for adolescents. You want to get up to at least 50% of persons answering. Some of you are shy. Okay, we have to 56%.
Great.
All right,
So
here we go.
the answer is all of the above. All of these methods are fine, safe, and appropriate for adolescents. And I think it's important to mention, LARC methods, IUDs, and implants aren't the end all and be all. Many methods work well for lots of women, but lots and lots of women and clients don't even know about IUDs or implants. And so if we're not talking about them and discussing them, then they don't even know about that potential choice. So it's good to talk about them, learn about them, and use them. Great. Next question is mandatory steps before placing or providing an IUD are A, obtain the client's weight and blood pressure, B, perform a pap smear, C, examine the cervix for signs of infection, D, all of the above. So these are mandatory steps before one would place an IUD.
Okay, we're at 50, so let's go to 60. 60%. So I'll end the poll now at 60%.
Great. So the answer is examine the cervix for signs of infection. Now it's true that, whenever a woman or a client comes into your office or client or setting, you do her weight and blood pressure, but it's not necessary. It's not mandatory for placing an IUD. We always do it. And the other one that I put there as a possible answer, I'm glad that few people said it. We do not need to provide a pap smear or do a pap smear before placing an IUD. So I'm glad that most of you, or a lot of you, got that correct. You simply need to look at the cervix, make sure it looks healthy, and place. You can go ahead and place the IUD.
Okay. Next question.
Contraindications for implants include A, hypertension, B, migraines with aura, C, obesity, D, breastfeeding, E, none of the above.
Okay. All right, so we're at 55%.
Great. So the answer is E, none of the above. And if you didn't know that answer, you could use your app that had medical eligibility criteria and put in the method implant, and then you could put in any of those conditions and find them, and then you would find out if it's safe to use for your client. So that's where the medical
Right.
eligibility criteria comes in. Great. Next question. If a woman does not time and space her pregnancies, risks to the newborn include A, greater risk of newborn death, B, less risk of preterm birth, C, less risk of small for gestational age, and D, more likely to be breastfed for 2 years.
It's a tricky one, that one.
Uh-huh.
But there's a good trend going.
Yep.
I shouldn't have said that.
But maybe stepping
can't
back a
see it.
bit, Mark, there was a question about in the chat about how in the past midwives were taught to do bimanual pelvic exam before inserting an IUD to rule out PID. And so just wanting to confirm that that's no longer the recommendation.
That's a great question. I'll touch on that. Maybe, yeah, if we have, when we finish with this question, I'll do that. That's a great question. Great.
Mhm.
So I
Okay,
think,
I think we get the trend on this one.
yeah. So it's greater risk of newborn death, mainly because shorter time spacing or short spacing between births leads to prematurity, mainly one of the, or early birth. So those in
And low
newborn,
birth weight, yeah.
low birth weight, those are
Yeah.
a greater risk for newborn death. Great.
Yeah.
So someone asked a question about checking for PID. That's a fantastic way to check for PID. It's,
Oh, Marcy, you can mute that person, please.
so that's a great way to, I mean, if a woman comes into you and you think perhaps she has PID, pelvic exam, pressing on her abdomen, doing a bimanual is a great way to feel safe or comfortable that she doesn't have PID. The more important thing to do is to look at her cervix and make sure it looks healthy, and that's really important. We used to also, there was another question I saw, we used to tell women to check for their strings after every period to make sure the strings are there. We do not need to do that, or women do not need to do that anymore. I tell my clients or patients that if they fear that the IUD has fallen out for some unlikely reason, they can for sure check and feel inside the vagina and try to feel the strings. And if they can't, then that would be a time you'd go into a clinic. But there's no need to check for strings every month as we used to tell women. So here, this next question that you're seeing is postpartum women can safely use hormonal IUDs or contraceptive implants. A, only if they're not breastfeeding. B, because these methods contain both estrogen and progestin. C, because the methods contain only progesterone. And D, because they contain prolactin. And the last answer is E, because they do not contain any hormones. So the question has to do with hormonal IUDs or implants and why they are safe in the postpartum period.
Okay, we are almost up to 50%. Let's see if we could get a 50%, at least a person's answering the question. Although we have a trend.
I'm wondering if the other 50% of people are just kind of sleeping or.
No,
I
for
think
some questions they go above, and then for some
Right,
questions
right.
they pause.
Right. And we should have mentioned it's anonymous, so we don't know who's answering what. So there's no
Right.
harm in answering. So the answer
right.
is,
Go ahead.
the correct answer is because they only contain, the only hormone in a LARC method, an hormonal IUD or an implant, is a progestin. And the reason this is important is because the estrogen levels are at their peak, they're at their highest levels right around the peripartum period. And, you know, it's hard to know if how the super being or God developed the women's bodies and systems, but estrogen helps the clotting mechanisms. And if you were to add more estrogen, then you could put a woman at risk for a blood clot in her vein, deep vein, or it could eventually end up in a blood clot in her lung. So that's why we avoid estrogen containing methods for that period around postpartum for about 4 to 6 weeks. And that also is in the medical eligibility criteria, but these methods are safe because they're progestin only. Thanks. Next question. When is it safe to insert a copper or hormonal IUD during the postpartum period? Choice A, 2 weeks after delivery. Choice B, 1 week after delivery. C, immediately within 10 minutes of delivery of the placenta. D, within 48 hours of delivery. Or E, C or D.
That should be C and D.
You're correct.
Right? And yeah. I didn't look at
yes,
that when I was
it would be
typing it.
both C and D, but not A and B.
Right,
Correct.
right.
And some people, I think, are not answering to the poll questions because their version of Zoom doesn't allow them to see the poll when it's a question. They only see the completed, the
Right.
answers.
So
Right.
let's just say now, seeing that we have 455 persons on, before our next webinar, I would suggest that you try to download the newer version of Zoom so that you can participate, not just in our poll, but in any poll that you are participating in any Zoom webinar that you may be participating in. You would need the newer version.
Great. So
Right.
the answer is many of you, most of you got 55% got C and D. So both immediately within the 10 minutes of delivery of the placenta or within 48 hours. And it's the idea is to help a woman get an IUD if that's what she wants before she leaves the hospital, before she leaves. And many times logistically it's tricky if, as Ann mentioned, if you haven't counseled her properly, you know, during her labor, or if you just don't have the instrument ready, you don't have the method, the IUD available to you right at the delivery bed. So you can place it before she goes home, day 1, postpartum day 1, or postpartum day 2 even, before she goes home, and safely. And that's the goal, is to help her get the method when she's at the hospital so she doesn't have to come back. And our last question is a true-false question.
Should we read the question? It says, after an abortion or miscarriage, a woman should wait 4 to 6 weeks before getting a contraceptive method, including a LARC. Is that true or false?
That's 42%. Okay, we should be up to 60% on this one. It's either true or false. At least 60% of persons should answer.
Don't watch me and smile because then I was
Man.
coming back. You ain't studying me. You ain't
Awesome,
studying
61%. All right, so we'll end the poll.
Great. So that was the last one. So the answer is it's false. After an abortion or miscarriage, a woman does not need to wait that long. She could get an IUD right immediately after, as a matter of fact, or an implant for sure, right after she has a miscarriage. And a trick that happens frequently, a woman would show up at a clinic and say she miscarried, a week ago. And oftentimes a clinic setting and many settings will do a pregnancy test, and the pregnancy test will still be positive, but you would be able to ascertain if she's pregnant or not by asking her a couple questions. If she tells you she had a miscarriage a week ago, she is not pregnant anymore, and you do not need to wait 4 to 6 weeks. So in other words, again, in fact, the best case is to do the IUD when she's with you. If you're taking care of her during a miscarriage or an abortion and she wants a method, that's a great time to give her one. All right. I'm going to show my face again, maybe. And I think there was a couple questions that I saw in the chat that maybe I can address. One had to do, there was a question about whether IUDs, I think the question was whether IUDs or copper IUD in particular causes an abortion or is an abortifacient. The short answer is no. IUDs do not cause abortions, and that's a myth that's been perpetuated so many times. So help your colleagues, help the doctors, anyone that you hear that from, please help them understand that IUDs do not cause abortions. In fact, then we talked about the mechanism of action. They prevent fertilization. They prevent the egg and the sperm from getting together. And that is not an abortion. I saw that, well, I answered the question. Checking for
Chanel, do you have some questions from the chat?
Yes.
Go ahead.
So we had another question. Is there a LARC course offered in the Caribbean?
Wow, wonderful question. I knew of one that I participated in that was led by PAHO, with PAHO funding in Guyana about 5 years ago now, I guess. Maybe they're doing others that I don't know about, but I don't know of any. If we can figure out the funding for it, I'm sure we could make it happen. But yes, the short answer is no.
Before we move on, are there any persons in the chat where LARC training is being done? Probably you can raise your hand. Anybody where LARC training is being done? I don't know of any.
So I'm aware that the IPPF clinic affiliates in the Caribbean of 7 different Caribbean nations are banding together to get hormonal IUD from the ICA Foundation. So I think they are organizing training, refresher training on hormonal IUDs. So
Okay.
I think the main organizer of it is in Antigua, but there's, I think, 6 other Caribbean, their network of clinics from the Planned Parenthood Federation are also
That's awesome.
joining forces.
Karen, where are you from? Can you unmute?
Karen.
Karen Wallace.
Karen Wallace.
I'm from, you're hearing me?
Yes.
You're hearing me?
Yes.
I'm from Manchester, Jamaica.
Okay. And they have a training program for long-acting reversible contraceptives?
Yes, we had it in 2021, November to December, we had it. It was for the copper T, the non-hormonal copper T.
Okay, awesome. Thank you.
In the process now, we're having midwives who are being certified.
Okay.
So I was one of them who was actually doing the copper T.
Okay.
Yes.
Thank you very much. So we do have some Caribbean islands where some of the methods we are having training, which is good. Go ahead, Chanel.
Right. So then we have another question. Should you wait 4 to 6 weeks post-delivery to insert an IUD to prevent expulsion as the uterus returns to the pre-pregnancy shape?
Okay, that question was answered.
Yes.
Right.
Then we had, which method is more effective, an IUD or BTL by tubal ligation?
Which method is more effective?
Which method is more effective, an IUD or BTL?
They're almost equivalent.
Mm-hmm.
Almost equivalent. And so, there's many women who don't have access to surgery. And so placing an IUD is as effective as having a tubal ligation. That's a great choice for someone who can't get to a surgical suite or find somebody that can do a surgery.
Okay. Is bimanual pelvic exam no longer required to insert an IUCD?
Yeah, that's a great question. I kind of touched on that a bit ago. Required is not quite the right word. It's a fantastic thing to do prior to inserting an IUD, so you get a good sense of the position of the uterus, whether it's tilted one way or another. But it's not required. But when I do trainings, I recommend it anytime you place an IUD, always do a bimanual ahead of time. But it's not as what's the word? It's not a mandatory thing, but it's a great thing to do. Just it helps you get a good sense of the position of the uterus and the size as well. But the sound will do that too. Thanks.
How soon after a C-section can an IUCD be inserted if not done in OT?
Ha! Oh boy. Well, I would first bop the person on the head that didn't put it in when the woman was when the surgeon was doing her C-section, because
it was an emergency section.
Oh boy. Well, if she wanted
you do need
one,
to have some counseling before you.
Yeah. If she wanted one and no one asked her ahead of time, and then she ends up in an emergency C-section, that's sad. But the short answer, you should wait for the uterus to heal up. So that would be 4 to 6 weeks at least. You don't want to push an IUD back through a scar or a healing C-section scar.
Okay. We also had, how does a healing placenta site affect IUD placement?
Like the inside of the uterine wall that a placenta has just been released from, like the placental site, it's not a worry. You don't need to worry about that. The uterus is incredibly well supplied with blood vessels, and it heals very quickly. Putting an IUD right at that spot will have no impact on its healing abilities.
Okay. We also had how long after removing an IUD would you can get pregnant?
Mhm. Almost immediately. The same holds true for an implant. So when you take in many cases, whether you're a woman who has a copper IUD or a hormonal IUD, she's almost always ovulating anyhow. So when you take the IUD out or the implant out, the return to fertility is almost immediate.
All right. I am not seeing any more questions that were posted. Anyone has any questions presently they would like to ask?
I think there's a couple people who asked about the size of the uterus in the immediate postpartum placement and the risk of displacing the device, which I think is a really good question.
Yeah. So An mentioned a little bit about the technique, and we've learned from many places, in particular Southeast Asia countries where they place to the tune of 2 to 3 million postpartum IUDs annually, and their displacement or expulsion rates are really low, in the neighborhood of about 3 to 4%, and it has to do with they've learned the technique and using what's called a long Kelly forceps or a long placental sponge forceps is really important. And to get around that picture shows the uterus. It's roughly the size of a volleyball or a good size ball when it's immediately postpartum, but it also has a slight tilt to it. So it's got a bend. So you need to kind of maneuver the IUD past that bend and get the IUD all the way up to the fundus. And the technique is pressing on the abdomen, the outside of the woman's body with one hand, and then sliding, you push the abdomen down and it pushes the uterus, straightens it out a little bit. And then you gently slide the IUD by holding onto it with a long Kelly forceps all the way up to the fundus, and then removing the Kelly forceps without pulling the strings right back out. It is a bit of a technique, but it's easily learned, and it's not a tricky thing. Like I've said before, you guys do a lot of things that are much trickier. So the displacement can happen provided you're not using proper technique and you don't get the IUD to the fundus. But if it's good technique, like everything else, provides low expulsion rates or high retention rates.
And I'm going to put a link in the chat for the training package that we have. And in that bundle of the training package, there's a video, which is an animation that shows exactly that technique and how you move the Kelly forceps out of the way. So if you're interested, you can check that out.
We have another question. Have you had any experience with a female becoming pregnant with an IUD? If so, was removal, how was removal handled?
Yeah, good question. So it's rare when that happens, less than 1% or less than 1 in 100. But if a woman does become pregnant with an IUD in place, the recommendation is to remove it if you can see the strings. So if you determine a woman's pregnant with an IUD in place and she wants to continue the pregnancy, you would take out the IUD as soon as possible. Oftentimes the uterus starts growing because the pregnancy starts growing, so the strings become retracted within the uterus, and then you can no longer see them. In that case, the only thing to do is, if the woman wants to continue the pregnancy, the only thing to do is to leave it in place, and you don't want to go trying to get it out. And just have to let her know that you follow her closely. She may develop preterm labor symptoms. She may go into labor early. She may develop an infection, but that's pretty unlikely. But yeah, there's nothing else to do if you can't get at the strings. But the recommendation is remove it as soon as you can if you know that she's pregnant.
Another question. Is it safe to insert individual for persons who did cryosurgery? Is it safe to insert IUCD, I guess,
Yes.
for persons who did cryosurgery?
Yes. Yes. Cryotherapy or freezing the cervix, thermal ablation of the cervix, or any of those methods, leap excisional biopsies of the cervix, all of those will have no impact at all on an IUD. So you should and can place one if a woman wants one. Every now and then I've had patients who have an IUD in place and they've needed cryotherapy or a loop, and I just kind of tuck the strings inside a little bit, do the procedure, and then bring the strings back out. So you can leave it in, you don't have to remove it to do the procedure.
We have another question. Can a woman who have had ectopic pregnancy, had salpingectomy done, can use an IUCD?
Yes. Yes, the short answer is yes. Ectopic pregnancy is not a contraindication for an IUD.
We have a comment. Some just come out spontaneously with a rupture of membranes. I guess this person was answering to one of the questions above with no injury to the neonate. So that was any question with the person who become pregnant with the IUCD.
Yep, and I often have patients who tell me they're nervous about having an IUD because they heard from their cousin or their sister's mother's cousin or somebody, oh, I heard that the IUD, was embedded in the head, or I heard that, it came out in their hand. And
he was holding on to it.
Yeah, exactly. And the only way to explain that is, you want to validate that fear, but the way to maybe help women understand that the IUD is outside the amniotic sac. And so it doesn't get at or cause any kind of an anomaly. But again, the main point is the chances of a woman getting pregnant with an IUD in her uterus is almost zero. It's really, really low. It does happen, of course, but it's really, really low.
We have just trying to find back this question. Would the positions of uterine fibroids allow a client to be eligible for an IUD?
Yeah, good question. So if you can't maneuver the IUD past the fibroid, then obviously it's not going to help. You can't get it into the uterus. But in general, you can put an IUD in with a woman who has fibroids. In fact, the hormonal IUDs will help a woman who has heavier bleeding with fibroids. It's actually an indication for the hormonal IUDs. It will help a woman. In lots of countries, hormonal IUDs are used for exactly that purpose, to help women have lighter periods that have fibroids and heavier bleeding.
Okay, one more question, Chanel. If there are any.
No, and I seen comments. Great presentation. Thank you for a good presentation. Empowered. Excellent presentation. Informative sessions as always.
Empowered. I love that word. You guys are empowered.
Yeah.
Informative. I have a question in terms of the grand multiparous woman. How would the IUD, so women who had 10 pregnancies, 11 pregnancies, is an IUD a good choice?
Yes, for sure. In fact,
ligation.
Well, yeah, if she's certain and she has access to surgery suite, and she doesn't want any more children, for sure, as triple ligation. But an IUD is a fine choice for her. There's often people worry that if a woman is a multiparous, that an IUD may be expelled more readily, and that's been shown to be not true.
Right.
Yes, and in fact, for sort of some of those women, you know, the IUD could be a permanent method because it will take them through to menopause and when they won't have to worry about it anymore. So it's a good alternative for people who fear surgery and are done with completed their family size, regardless of whether they have 4 or 5 or 1 child, because it's so long acting.
But I guess we could close up. It would be a great asset to add early insertion of IUD immediate postpartum here in Antigua. This is a comment from Antigua.
Yeah, you know, I guess we could figure out a way to do a virtual training with models, but it's not that hard a skill. So yeah, anyway, I agree. I hope somewhere along the way we'll figure out how, or you guys can figure out how to get trainings in lots of different places.
Okay.
This would be the last question. Can IUDs have any effect on menopause?
The non-hormonal IUD, the copper IUD, the answer is no. But the hormonal IUD, yes, likely will help a woman in that perimenopausal and even the menopausal range of having no periods. And it probably won't affect hot flashes, but for a hormonal IUD, in fact, there's a recommendation to leave it in roughly 5 years or so past menopause.
And before I turn you back over to Kathy, we had a comment where someone had triplets, with one of the triplets being born with the IUD in arm. That was one of the comments. So we
and triplets.
Yes. So we closing off the link. Julia, so you put the link?
Yes, ma'am.
Right. So
Yep,
there's
turn back to Kathy Ann.
Right. Kathy Ann, we're going back to you.
Okay. So this was definitely a very informative session. And as persons would have indicated, as per usual, we saw 458 persons taking time out to get this information, and I trust it was well received. And we want to thank our presenters, thank the educational committee for once again making this webinar possible, and our participants with whom, if we don't have you all, we don't have a webinar. So I want to just say thank you. And I don't know if our president wants to have a few words before we close off.
No, just to say, to reiterate, thank you very much. The Google form link has been put in the chat several times. I'm going to put it there again. This form must be filled out, completed, and submitted so that you can get your certificates and your CE hours. You must fill out that form. We do not take emails out of the chat to send you your certificates. We appreciate the attendance of all. We work it on the honor system. If you know that you missed most of the presentation, then we don't anticipate that you would request a certificate. So we were here from 7 until 9. So, you know, if you came on at 8:30, you missed most of the presentation. If you came on at 8, if you didn't hear Mark's initial presentation, you missed too much for your certificate. If you only heard Anne's presentation, you only had half of the presentation. So we work on the honor system, and we would hope that you would fill out the form accordingly. But thank you very much for coming. And let me do roll call. We had St. Kitts and Nevis, we had Jamaica, we had Guyana, we had Dominica, we had Belize, we had Barbados, we had Trinidad and Tobago, we had the Bahamas, and multiple islands. I saw Exuma, Cat Island, Grand Bahama, Nassau, very good. And some persons didn't put their island of origin, but that's fine. We had Antigua, we had St. Lucia, we had Montserrat, and we had Turks and Caicos Islands. If you did not hear your island, put it in the chat.
Did you call Guyana?
Yes, I did call Guyana.
Right.
I see you, Grenada. Anybody else that we missed other than Grenada?
You called St. Lucia?
Yes, I called St. Lucia.
Belize.
Yes, Belize was up top. Yes. So it was good having all of you ladies. If you're having any problems with the Google form, please let us know.
Jamaica.
Oh, yes, we called Jamaica. And St. Kitts and Nevis.
Did you call the Bahamas?
Yes.
Yes,
she
the
did. Many
Bahamas and
islands.
all of
All the islands.
Because they're getting very specific now. They're telling
telling
me
you.
this is Cat Island, this is Exuma. So I must acknowledge. Oh, let me stop the recording.